Thank you very much. I'm not entirely sure whether I should chance it or just say next, but I'll try, and if we get stuck, either I'll do the entire talk from the title slide or I'll ask you to advance. Thank you very much, Jens, for inviting me here, and I'd like to thank the previous speakers yesterday and today for providing such wonderful talks. Very different, right? The talks that they provided were very different in two aspects. One, they were experts in what they were talking about, and this is not the case. And the second thing is they provide a lot of scientific and quantifiable data to back up what they were saying. Yeah? So there's no argument. If you see that formula that you showed on DTI, there's no argument. Nobody's arguing about what that looks like. This conversation is very different. This is based on personal experience, on observations and assumptions, very little scientific data. So it's open to question, and it's open to provocation, and hopefully stimulate some thought. So I should give a disclosure that my views are personal. They don't represent my university, don't represent my department, don't necessarily represent the views of anybody I work with. What are they based on? Well, I've had the pleasure of working in many different institutions, firstly as an emergency physician in a regional trauma center, then as an internal medicine physician, and then as a radiologist. I've worked in Tier 1 community hospitals, worked or trained in community hospitals really small that very few of you in this audience would know anything about. I've worked in academic powerhouses, which you will not be familiar with. And one thing that's been very common in all those places is that wherever you go, there are good people. There are people who want to do the right thing, and they're trying very hard to do the right thing. But there are hospitals I've worked in where the culture's been very empowering, where people feel that they're valued, listened to, supported, maybe a positive culture. And there are other places where similar size, similar sort of functionality, the opposite. People might call it a toxic culture. And it's hard to know why the difference. And some places will transform. They'll go from what felt to be a positive culture to a toxic culture and the other way around. And it's always been a little bit bizarre as to why that should be. And it could be that I'm the only person in this room that's felt that, and maybe you guys have had great experiences. And so I've wondered why that should be. And there's no simple answer, but there are some thoughts I have. So you might be wondering why I've got a picture of Patrick Regala up here on the slide, right? And unfortunately he's not here, otherwise I would have said other things. But in seriousness, I mean, there's Arnold Schwarzenegger. And in fact, people like Patrick and other of our speakers have something in common. Someone like Schwarzenegger. It's not the gym, in case you're wondering. What it is dedication and focus. So the picture on the left is Schwarzenegger when he was 15. He decided he wanted to be a world-class bodybuilder. So he set out a 10-year plan of training, nutrition. He set out to work with the best in the field to get better at what he did. And he knew it was going to be 10 years plus. He knew it was going to be hard. He knew he couldn't party. He had to go to the gym 2 hours in the morning, 2 hours in the evening. A lot of pain, but he could see the gains. And he stayed the course. So he was focused on something that was important to him. There's lessons for that, for all of us. And those people that you've heard talk before me have, in their own way, had that same journey. They've been dedicated to do something special, and they've had some obstacles that they've had to overcome. They've had to make sacrifices, right? But they kept true to their purpose. In the same way, in my opinion, each of us is responsible in our work environment for what we work in. We all create the environment and the culture we work in. We all have some degree of responsibility, right, on our interpersonal level. But leadership becomes really important for a small team, for a department, for a hospital, or for a company. Because at the end of the day, it's the leader's responsibility to provide focus, provide clear communication, provide a sense of support and integrity to the process. And there's a quote that I saw just the other day saying, it may not be your fault, but it's your responsibility. Right? So this is something that I'd like to build on as we go forward. So my disclosures are that I do Speakers Bureau for Canon and for Biomedical. I see that's not advancing, right? Okay. Biomedical, and I have received research grants for my PhD and master's students, and they've all qualified, so that's all good. So the other thing I'll say is there are very few facts in this conversation, but a lot of it's going to be observations. Some of it's going to be assumptions, And lastly, hopefully none of it's going to be fake news, made up, or anything of the sort. So the learning objectives is we're going to discuss during the conversation some of the factors that necessitate change in the healthcare system because it needs to change. We need to understand the difficulties of change management, and it is painful. It's not easy. Those of you in the audience have tried it. Some of you have been successful. Some of you have been scarred and still been successful, and some of you are still trying. And trying to explain some strategies which we can use for successful cultural transformation in the healthcare system. So in essence, what I'm going to do is say why, right? When we're talking about change, we have to say, why are you trying to do what you're trying to do? And then we're going to say, what? What is it that needs to change? Who needs to be part of the change? In case you're wondering, that's the 95-96 Newcastle United team, which was the second successful team in the Premier League, meaning they won nothing. But anyway, how do we do this change? Where does this change take place? When? What's the right timing for this change? And lastly, if you do all this stuff, you make the changes you want to make, everything's going perfectly, so what? Did it change anything for the patients? Did it change anything for the team? So whenever we're sort of trying to say we need to do this, this or this, someone in the room should ask, well, if you're successful in everything you've done, did it make a difference? And if it didn't, why are you doing it? So cultural transformation. If you look up the word cultural on the online Oxford English Dictionary, and I have suspicion that this is not the online Oxford English Dictionary because behavior is spelt wrong, culture is the attitudes and behavior characteristics of a particular social group. So on the left, it could be Canadians, right? A mosaic, cultural mosaic. People coming from all parts of the world, enriching our society with different ideas, different backgrounds, but to a common aim. And it could equally work in a medical imaging department or a hospital, where you have people with different disciplines. You might be a technologist, you might be a radiologist, a nurse, an administrator, a receptionist, clerical, and those are different cultures, right? How do you, if you're going to change something, how do you transform that culture with all those different backgrounds and beliefs? So talking about healthcare, we're going to talk a little bit about the challenges of the healthcare system, and I want to base it around the patient's journey, because too often we base it around the equipment, or we base it around what happens in a hospital. Well, the patient's journey is very different from that. And then we're going to talk about medical imaging, how might we make a difference, and how do we introduce innovations in patient care. Okay, so most of you should be familiar with this chart. If you're not a taxpayer. Okay, so what's happening decade after decade, we're spending more and more on healthcare, and it's not sustainable. Part of the reason for this, it's only part of the reason, is shown in this graph. So we have three columns. First column is the population of Canada in 1971. Middle column, population of Canada in 2011. And the last column is the population predicted of Canada in 2030. The green bars represent the number of people in that age bracket. The blue bars represent the fastest growing segment of that population. Okay? So if we take the first bar, 1971, Canada had a population of 22 million people, and it was a population pyramid. So more people in the younger phase, less people in the middle ages, and a small number of people more than 65 years old. And that's sort of a typical population pyramid of a sort of developing country or a young country. Okay? So by 2011, population has shot up to 35 million, and now it's no longer a pyramid, it's more like a sort of a rectangle, and the largest growing population is 45 to 64, which we agreed yesterday was still young. I think we agreed, right? Still young. If we project forward to 2030, population will be 42 million, and the fastest growing segment is going to be older than 65. It means two things. One, it means the people who are paying for the nationalized system, socialized system, i.e. the taxpayers, are going less. And we're going to be spending more. Next, please. And we're going to be spending more because we're going to see, with the aging of the population, an increasing complex disease. We're going to see multi-system disorders. People aren't going to be coming with just a problem with the lungs. It'll be lungs and kidneys, or a heart and kidneys and livers and stuff. Complex disease. And chronic disease, because they're not just going to come for one episode, they're going to come for multiple touch points on the healthcare system, so long-term care. We're already seeing that 80% of healthcare spending in Canada is on 20% of the population already, and that's before we get this massive growth in people who are older. So things have to change. We cannot continue the way we're going, because if we kind of go in the same direction, do the same things, we'll kind of end up where we're heading. It's kind of self-evident. And we cannot go in the same direction. So let's talk about the patient, okay, and let's see how the patient might experience the healthcare system. So person's at home, this could be Jens having a party, who knows, and you're feeling unwell. Something happens, so you want to, maybe it goes away, maybe you decide you want to see somebody. So if you're fortunate, you have a family doctor. If you haven't got a family doctor, you go into a walk-in clinic. If you haven't got either of those, you may attend the emergency department. Not a great use of resources, but some people don't have a choice. Often, the episode ends there, right? You're seen, everything gets better, and you go home. Sometimes, you may go to your local community hospital, maybe a tier 1, tier 2 center, right? And the episode gets resolved. Sometimes, you may have to go on to the academic health science center, so a longer period of stay, more complex disease, and then either you go home or you may have a period of, go back one please, yeah. You might have a period of rehab, a nursing home, a rehab center, and party away, right? So that's kind of the way it might work. The problem is it's not integrated. So some of us who've had family or perhaps personal, one episode, it might work very well. But if you have relatives or family members or friends who've needed long-term constant touch points in the healthcare system, it breaks down because it's not working together. It's not integrated. And I've illustrated on the left the 4x1 Canadian Olympic gold and the 4x1 GB gold relay teams. And the reason I've done that is I wonder if anybody here can name all 8. And I suspect you can't. And the reason for it, it didn't matter that individually they were superstars. In fact, they weren't. The US teams and the Jamaican teams had faster individual runners, 4 individual runners. The reason why these people won the race is because they were a better team. They were integrated better. They did what they did in a better way. So you could have an academic health science center, which is a superstar. It doesn't matter to the patient if they can't access it, right? So what we need to do is see how the system works better together. Next, please. So barriers to integration. It's about people. It's not necessarily about money. It's about, we always do this way, the culture, perhaps ego, perhaps turf, perhaps a lack of overall supervision, and some of it will be infrastructure, particularly when it comes to medical imaging. The problem is, how many of you have gone into an environment and you say, let's do this, and the answer is, we've always done it this way, or we don't do that here? How many? You don't have to put your hands up, but I know it'll be most of you, right? And that's a killer. What does that mean? We're not willing to listen, okay? See you, Heidi. Nice that you could come. You don't think I was going to let you sneak out? Yes, I'm a bully. What can I do? So even whether you like the Patriots or you don't like the Patriots, nobody can argue, or maybe you can, they are the most successful organization in sports in the modern era. 6 Super Bowls, right? 9 Super Bowl appearances. And the philosophy is you cannot sit back and say you've been really good in the past. You have to adapt to the current and future. Because if you don't adapt, you're going to come up short. This is the problem. When you talk to folks in your data, everybody says, this is a great idea, let's do it. Let's do it. Who wants change? We all want change. Here's the problem. Who wants to change? Change is something that somebody else has to do. I'm fine. I'm doing great. And this is the problem. It's always somebody else. It's always somebody else's problem. So, in any team, and this is a personal thing, it's not the 80-20. In my opinion, it's the 20-60-20. When you come into an environment, whether you're in industry or whether you're in healthcare, 20% of people you talk to are keen. They're really keen to do, let's do it, let's do it. You said, I haven't told you what we're going to do yet, but let's do it anyway. 60% cautious. Yeah, sounds interesting. Maybe. What are you talking about? Let's think about it. And 20% say, are you kidding? You really? Where did you come from? Why are you here? And you might say, so where do you put your energy? If you're trying to lead change, where are you going to put your energy? The fact of the matter is you can't ignore any of these folks. You can't. You have to engage them, but where are you going to put your energy? And there's pros and cons to each. So the eager beavers, they're early adopters. Let's do it, but they're also early to be disappointed because they thought it was going to be quick. They thought it was going to be change. Let's do it, and now you haven't delivered. Right? So you have to deliver if you're going to change. The cautious folks are late adopters, but they might stay the course, but don't think you're going to get a medal. right? Because there's always things that you need to do. Very considered approach. Resistance, whatever you do, they're going to be disappointed, right? So you can put a lot of time and effort. And if it's interesting, if you have US, American, British, and Canadian audience, I'm going to guess which way they vote. And I know I was at a group when we talked about this kind of thing. The Canadians will always try to help the resistors. They say, no, we all got to go on the same boat. We've all got to, and we're going to do it because we all should be the same. The Americans will say, let's get the eager guys. They're the guys that are going to succeed. Whatever we put in, it's going to be redoubled. And the Brits will say, well, the Brits don't know what they want, right? So, but generally we'll say, let's shift the bell curve. Let's go for the middle group. We can't ignore everybody. So you have to figure out in your own environment where you're going to put the energy. But you only have so much energy, and you have to have early wins. So for my personal view, when you're going to try to change something, it's not about looking back. It's important to know the history of why you are where you are, because it explains a lot. But you can't put your energy in the past. You have to put it in the future. If you spend your time looking over your shoulder, you're not looking where you're going. Having said that, the folks that you'll engage with, it's important to them why things happen the way they are. So you have to balance. It's not ignoring people, but it's not putting your energy in why things were the way they were, how you're going to build something new. And everybody says they want global impact, they want to be great, and they want to do this and that and the other. And the fact of the matter is, it doesn't just happen by chance. You have to plan it, just like Schwarzenegger, just like Patrick. You have to plan how you're going to get there, and it has to be a staged and phased approach. It doesn't just happen. You don't just win the lottery. It's about discipline, it's about choice, and it's staying on track despite the pain of change. So, here's some ideas. This is what we're doing in London, and we've tried to create a focus, having engaged with the various teams. One of the things I will say is, if you're going to try to make change, it has to be relevant to the team. It has to be important to the team. It has to resonate that this is something that we can all believe is important. So focus. 4 areas of focus that we've put together is safety, patient safety, and the safety of the team. And that could be in terms of minimizing radiation dose, whether it's a CT scan for a patient or reducing the radiation dose in the angio suite. Patients, we all talk about patients having reduced dose, but the patient may only have that exam once. But the interventional radiologist, the nurse, technologist who's in that room is getting exposed every day. What about them? What about their safety? This also brings up another point. Sorry, I keep jumping around, but we always talk about patient care, patients and their families in care, and patient-centered care, and that's very important. But we also need to talk about the team looking after the patient, because if the team is not healthy, how are you going to deliver best patient care? You can't. Sideline that. Anyway, so techniques that we use like ultrasound and MR, we want to minimize the heat, and we want to minimize the amount of intervention we do. That means for someone like Banco, use a smaller catheters perhaps, not doing no catheters, right? Smaller radial punctures rather than femoral punctures. Speed. How do we become more efficient? That doesn't necessarily mean working harder, it means working smarter. How do we become more efficient? How do we address the wait time access that issues we have? How do we get patients, when they're in the scanner, in and out faster than we do at the moment? But yet still treat them with some respect and individuals. We're not putting conveyor belts, throwing people in the MR or the CT, right? So we've been asked to move patients in and out of rooms quicker, but we're also asked to respect their needs and ask questions. So how do you balance those two things? Specialization. We've seen a lot of imaging in the past on structure, but you've seen today and yesterday that we're going more towards function and physiology, whether it's tissue characterization, whether it's perfusion, whether it's with ultrasound and the scrotal 33 megahertz probe, or whether it's on CT brain perfusion or DTI. So we're really sort of pushing towards better, more accurate disease characterization, early response to treatment. And most of all, though, we need to create a special experience, not only for our patients, but for our teams. Why is it that up to the last 3-4 years, an MR scanner or a CT scanner, the patient's already worried about what's going to happen to them, and they walk into this room that looks like a laboratory. It's a bare room, it's got this big machine and a tunnel in the middle, hits them straight away. If their heart rate wasn't going up before they went into the room, it certainly is when they see this machine. So manufacturers are getting much better at masking the machines, making them a little bit more acceptable, and we need to really embrace that. So those are the four sort of areas of focus. But there's 4 pillars. If whether you're in an academic environment or a community hospital, I don't see any difference. You may weight things differently, but I still see that you need to have some sort of innovation. The innovation in research, clinical translation, knowledge translation, and outcomes analysis. By the way, that's a picture of the AIC for those of you who are sharp-eyed. Now, why do we need research innovation? How do you change the standard of care in the clinical space if you don't bring in new ideas? Because otherwise you're doing the same thing you did last year and the year before and the year before. And we know the needs of our patients change every day, every week, every month. So we need to innovate. Whether we borrow ideas that somebody else has researched or whether we create our own. Research is a part of clinical care. And until you acknowledge that, you're not going to invest in it. Because in many hospitals, research is done somewhere else, and clinical care is done in the hospital. That's old. So you have to commit time and resources to perform innovation or research that's appropriate to your environment, but it should be taking place in every medical imaging department in the country, in my opinion. You have to have partnerships, and this line will be the same for everything I say. You can't do it on your own. There's not enough resources, right? And we need to have support. So whether you have scientists, whether you have colleagues in sort of cardiology, neurology, neuroscience, etc., industry, companies such as Canon and others, and government, federal funding and grants. You've got to pursue these. Once you've validated something in the research space, you need to bring it over into the clinical space, right? And translate it straight away for the benefit of your patients. Once you've shown that your patients do very well with it, you have to make sure that you derive the clinical excellence in your department. You have to make sure you commit the time and resources to make sure you translate that work over. And again, it's all about partnerships. Once you've validated that new clinical technique in your environment, you need to spread the knowledge. You need to share that with other people, the other hospitals that might benefit, right? Dissemination of knowledge. And I would say here that workstation-based teaching is a minimum requirement. If you're a technologist, you often teach on the job to students. That's a minimum requirement. I don't think that's the end of teaching. We need to provide dedicated sessions, whether it's simulation, whether it's dedicated time above and beyond. Time resources to dedicated teaching and to the environment, and again, partnerships with our colleagues in industry, other scientists, and government. Lastly, and this is where we kind of don't do so well, perhaps, this is where our interventional colleagues do really well. The outcomes are pretty good. Somebody walks in with a cold leg, embolectomy, they walk again. Come in with a stroke, you do a EVT, the arm moves. Very, very good outcomes. Less easy to look at the outcomes on a ground glass nodule that you've been following for 2 years. So we're not really good at showing the value of what we do, and we really need to understand how can we show that? How can we show that getting a 320 CT for cardiac CTA is more valuable than a 64 slice, right? Because that's what we're doing. So we need to really understand that. Fortunately, Russell Bull has shown us how, all the sort of the path to that, so we've got something to work on. So it's critical to understand whether we're making a difference, because if we're not making a difference, and someone who's paying the bill is going to say, why are you doing this? We have to dedicate time and resources to outcomes analysis, and we need to partner with our colleagues, as I said before. So some people have good intentions. You know what? We should really do this. Some people really wish some things would happen, and others make it happen. So who are these people? I've mentioned about leadership before. Leadership is really, really important, and this is kind of a generalization. I haven't met anybody who falls all in one column or the other, but you may think of yourselves, if you're a leader, where do you fit on this? And if you're a subordinate, you report to somebody, how do they fit? And a generalization is, generally speaking, have you got a boss or a leader? Are you a boss or a leader? Do you demand or do you coach? Do you kind of say, I'm the boss and you have to do this? And by the way, if you ever have to say you're the boss, you're not. You know that, right? So, and you have to model the behavior that you expect from your colleagues. Do you issue ultimatums from a desk, for an email, or do you try to bring people in and generate some sort of enthusiasm about the project and why? Do you develop your people, or do you always get them to do things and say, don't give them any time or resources to develop their skills and develop them in their career? This is a big one. We all know places where things go really well and the leader will say, well done, guys. And if things go badly, they take the blame. And we also have environments where it's the opposite. Who would you prefer to work with? Same thing. Is the leader part of your team? or is he part of a delegation team? And again, are they humble enough to be open to other ideas? So it is possible to transform, and things like, and I've talked about partnerships and everything like that. We, in London, have announced a major partnership with Canon Medical. We're going to be the world's largest installation of Genesis equipment. We'll have 6, 1 research, 5 clinical, and a prime for intervention. And we're going for at the LHSE site, somewhere where we've got very old equipment, stroke center and our cancer center. We've got phenomenal technologists and radiologists doing a great job despite the fact that the equipment is unreliable. It's kind of like this AV system. It works, doesn't work. But the partnership is across all the 4 clinical pillars. And when we give our teams the right tools, I can only imagine what they're going to do, especially in partnership. So it is possible to change, but you have to put the work in. The when and where, well, we should be doing change all the time. Here's a possibility. So with the Ontario health teams, the proposals being healthcare systems, maybe an academic center, some community hospitals, mental health services, the rehab services I was talking about. Can you guys who are doing this work present a case to the government to say, let us handle this work, give us the money, and we will sort it out? So proposals have gone in. The population covered for each proposal is about 300,000. Interesting enough, the website says 150 proposals went in. Now this is for Ontario. If you do your sums, that's 45 million people. That's more than the population of Canada. So I'm not sure what the proposals were. Maybe there's some double counting, I don't know. But I'm very excited that hopefully we can get the people doing the work to drive the way patient services should be delivered in a particular region. So we talked about cultural transformation. So what? So what if we do all this? What if we get these areas of focus, whatever they happen to be, safety, speed, specialization? What if we get the academic pillars working from research to clinical, have an active teaching program and look at outcome metrics? And what if we build these scientists? Is that it? Have we done everything we need to do? Because there are academic health science centers in Canada, across the US, and the UK who are doing all this. Is that it? Is that as good as we can get? Well, what about the patient? You could still have all that, and the patient could still fall through the system. So they could still go through the process where they're being referred from a GP or a community physician into a hospital and then into the medical imaging subspecialties, but they could still be stuck. Here's my hope for artificial intelligence. We've heard a lot about using deep learning for brains and for cardiac and various things. But what about, look at the experience what people have now. So you go to your family doc. You take the history, you get an examination if you're lucky, and they say, well, you need this. And they'll refer you to somebody in the hospital for further analysis. You wait for an outpatient appointment, you get to see them. They send you for imaging. They say it's the wrong test, it comes back. Then they send you a date. You can't make the date because your support services can't work for it, and it takes months. Well, what if you could use deep learning? You're at the GP's office. They start typing in your symptoms and your age and everything, and the deep learning system starts looking at appropriate criteria which are published everywhere in the world for your particular symptoms, starts to sift through the various algorithms. Then it says, actually, in this your particular case, a 45-year-old male with chest pain or whatever, this is the test that's most appropriate. Then it starts to access the booking, the hospitals around who give that test. Then it starts to look at the booking schedule for that particular test at those and says, Mr. Smith, you could have a CTA done here, here, or here. Here's the date. Can you make any of these dates? You say, I can make that date. You plug them in. They get the appointment. They get all the preparation, and they get it right in front of them with a smartphone. Why can't we do that? It's fabulous that we're going to use deep learning for all these other things, and that's great, and we're going to lay off radiologists and all the rest of it. But why don't we actually try to help the patient? The biggest problem with our system now is patients accessing convenient to them. And we waste so much time and money rebooking, bookings. Patients can't come. Patients cancel. I'd like to see deep learning address this piece. And you might say that's too big. Well, I'm saying if you're not dreaming, if you're not trying to push the system, what the heck are you doing in the system? Our job is to try and adapt for the needs of our patients. So, in summary, why would we want to change things? Because what we're doing now is not sustainable. We can't afford the healthcare that we want to provide for our patients. Patients are getting older. We're going to have multi-system disease and chronic disease. What do we have to change? We have to try to integrate this system of care. because it's not integrated right now. Who's going to do it? Well, we are. Knowing that we're a heterogeneous group, early adopters, cautious people, the people who say, not for me. We've got to try to move the system together. How are we going to do it? We need some sort of focus. Whatever your focus is in your industry or in your department, you need to have a focus. We need to do this within the next 5 years. Within 5 to 10 years, this is what we're focused on, and we're going to complete that. Where are we going to do it? Well, in Ontario, there's a lot of promise for these Ontario health teams. If those of us who have been in the UK, we've kind of seen this before, and we're maybe a bit jaded, but there's always a chance that we've learned from the past and we'll do things differently. And the so what will be, it's about the patient. If we can look at from the patient's lens and make things different for the patient, they'll understand the taxes that they pay are directed towards making things better for themselves, not about buying rich toys or expensive toys with fancy buttons. Change will come, but it'll only come if we do this. This is the right time. This is the right time for change. We're the ones we're waiting for, and we're the change we seek. We can do this, but we need to go through the pain in order to achieve the gain. Thank you very much.